Good evening. On a Sunday afternoon, it is such a pleasant duty and indeed a great honor for me to introduce this best series, Beat Epilepsy, Stay Informed. And I believe this is the eighth in the series, a monthly series of epilepsy awareness webinars under the aegis of the Indian Epilepsy Association. And this time it is the turn of the Kochi chapter of the Indian Epilepsy Association. Thank you, Mansi. They have quite appropriately chosen the topic epilepsy in adolescents and young adults, something which is extremely important. Before we actually hand over the floor to the moderator for the discussion today, which is Dr. Rajendran, who is a very senior and well-known neurologist working at the Avitas Institute of Neurosciences in Palakkad, Kerala, and also is known, very well known to everyone because he was before this, formerly the Secretary General of the Indian Epilepsy Association. There are a couple of housekeeping announcements. I request all the panelists. The discussion would be held initially between the panelists from Kochi, whom Dr. Rajendran would introduce, and others who would like to pose questions or provide their own views, give their comments. This could be reserved for the question and answer sessions. Request everyone, particularly the attendees who might not be members of the Indian Epilepsy Association. This is an excellent opportunity. Here are some of the benefits of becoming members of the Indian Epilepsy Association. And please do consider applying for the membership of the Indian Epilepsy Association through your local chapter. And you have a list of all the chapters of the Indian Epilepsy Association on the website. So with these few announcements, again, it is a pleasant duty for me to request our president, worthy President Professor Vengamma, to set the ball rolling and inaugurate and set the proceedings for today's session in order. So Dr. Vengamma, please. And after that, the floor will be taken by Dr. Rajendran, who would then go on to introduce the topic as well as the panelists for today's session. Dr. Vengamma, please.
Good evening to everybody. Am I audible?
Yes.
Good evening to everybody. Thank you, Dr. Gagandeep, for the introduction. I welcome everybody for this eighth series of our best series of webinars. I think for the last 10 months, we have started on August 15th for the first webinar. And except for 2 months, like in February, we had a break for International Epilepsy Day celebration. And last month, April, we didn't have. Otherwise, regularly for the last, this is the 8th series of best series of Beat Epilepsy with Stay Informed, like our best series. And we have discussed many topics and like epilepsy in children, epilepsy in elderly, and today's epilepsy in females, like ladies and women, and all other important topics like epilepsy and women and other issues are all discussed, epilepsy and driving. I think today's topic is very appropriate to the present day discussion about, because the adolescence is the most toughest transition between a child and an adult, and it's really challenging. Many challenging issues will be there this adolescents and young adults, and I really thank the Cochin chapter President Dr. Matthew Abraham, and Secretary of Kochi Chapter KP Vinayan, and Treasurer, and today's moderator Dr. Rajendra, and other panelists Mrs. Suchitra Narayanan and Dr. Dhania Chandran for their active participation and taking interest to be the part of today's panelists. As on my personal behalf as a president, I welcome all the members of IEA and IES executive, past presidents and secretaries, and some of the senior members also have joined, and I extend my warm welcome to all of them. And with this, I wish this program is going to grant success, and with this, I make it as a that today's webinar can be inaugurated and started, and my hand over to Dr. B. Rajendran, who was the former secretary of our IEA, and he is going to moderate and introduce the panel discussion and take the further discussion forward. Thank you, Dr. Rajendran. Now I hand over to you.
Thank you, Dr. Vengama and Dr. Gagandip. First, let me say my appreciation to both of you who have started this webinar series. It's been wonderful. So I think that credit, I mean, it's amazingly beautifully done over the last 10 months. Okay, so congratulations to both of you. And now let me introduce first the panelists. Dr. Matthew Abraham is a senior consultant neurologist who is a very good clinical neurologist with vast interest in different aspects of neurology, not only epilepsy. He is now with the Aston Medicine as a senior neurology consultant. Dr. KP Vinayan, neurology circles will know him. He is a brilliant pediatric epileptologist, not only holding the post Professor of Pediatric Neurology, but he is also a member of the International League Against Epilepsy Task Force. That is Dr. KP Vinayan. Then comes Dr. Dhanya. She is a clinical psychologist associated with the Amrita Institute of Medical Sciences. And they have a large number of patients with epilepsy. She is actively involved in the management of that. Ms. Suchitra Narayan. She doesn't require any introduction because she has delivered one of the Bajoria orations earlier. She is a very passionate member of the Indian Epilepsy Association. Mainly, her area of interest has been working with children with difficulties in social skills and also other disabilities. And she has got her own center. She is very passionate about helping children with their problems. And she is a great advocate of, let me say, put it this way, about we being proactive rather than getting others to be helping us. So these are the panelists before you. Then why did we choose this topic? I think I should primarily say that also. Because this is like Dr. Vengama said, this is the problem of transition between a young adolescent and an adult. That is where hormones are raging. Biologically and sociologically, this group of children, even without epilepsy, they are under a lot of stress. So this group of patients with epilepsy will have much more stress factors affecting their life, their future, their career. For the simple reason, these are the people who are going to be maybe our next scientists, doctors, engineers, and also social scientists, artists. So these are the people who are going to be our future. So that is why we chose this group of patients with epilepsy to be addressed. What are their problems and how can we address them? So with this few words of introduction, first, let me ask Dr. KP Vinayan. These hormonal changes during adolescence, what are the effects on seizures and seizure control? How would you manage them? Dr. Vinay?
Yeah, thank you, sir. As the Secretary of Indian Epilepsy Association Kochi chapter, I would like to thank the Indian Epilepsy Association Central Office to select us for this webinar on this day and for arranging all the logistics here. So, coming to your question, sir, the hormonal changes and epilepsy and how it affects, especially in adolescence. The main thing is there are multiple ways. This is actually a multi-directional thing. One is the hormonal changes are natural in any person who is moving from childhood to adulthood, and adolescence is a period of transition, as we have discussed here. During that time, basically, there is two things, especially in ladies, there is a specific time that marks that adolescence, like menarche. But in boys, it is actually spread out over a period of time where we have different things happening. The hair changes occur, and then the hormones, the other body changes occur, and there is the mental changes occurring, and then the sexual interest changes. So all these things happen during that time. So there is a whole lot of things which we can discuss regarding the behavior and the changes during that time. And there is a lot of stress, as you have already told. There is a lot of confusion regarding the long-term things. So that we can keep it aside. And at this point, we can talk about specifically on the seizure aspect, the epilepsy aspect of it. So if you look at as a pediatric neurologist, I would like to put it like this. Basically, there are some epilepsies or the seizure syndromes which usually go away during the beginning of infancy, like some of the idiopathic generalized epilepsies like absences, idiopathic focal epilepsies like this, centrotemporal spikes. So there are some good news there. So the seizures may usually stop when the child reaches adolescence. So that is the way I put it. So then there are other syndromes there which is starting at that age. So why it is starting at that age, it is not very clear. But some seizures like juvenile myoclonic epilepsy, juvenile absence epilepsy, and then you have the other idiopathic generalized epilepsies which starts in the adolescence period. So these seizures are a little difficult because this is the syndrome where usually it has got a long time to get controlled, because it will not get controlled that easily. So people should be prepared for a long-term management of seizures and other associated stuff. So this is the adolescence on the epilepsy. So then the other question is whether the epilepsy will affect the adolescence. So the change of hormonal changes. There are some studies like that which says that if you have a very frequent seizures, you can have an early menarche, early changes, or you can have later changes also. So it's not very clear, but you can say that if you have a frequent seizures which is coming from some parts of the brain, it can actually affect your hormonal changes the other way around also. So then the other question is the drug issue. So the drug issues and the hormonal changes, there is a definite evidence that some of the drugs can affect this the hormonal axis in the body, and it can lead to abnormal changes in the ovaries, in the system, and then can have early menarches. We have seen some children going into early menarche because of the long-term anti-epileptic drug treatment, and then it can also have delayed thing also. So basically we can't actually generalize things. So the advice is you have to be careful during this time regarding the hormonal changes, and then talk to your physician if you feel like there is something abnormal which is happening, like significant disease. Already, especially in girls, there is a chance that irregular cycles can occur in the period of adolescence. So if it is going out of hand or there is some significant irregularity, you have to talk to your physician. See, basic thing which I would advise here is there are general things, but individually it is better if you feel like there are some changes, talk to the physician, and we may be able to adjust from our end regarding these medications. So it will, and it's a general idea, sir. So if you have something specific, I can elaborate further.
Actually, Vinan, it's very well put. I'll come back to you on certain things which you mentioned a little later. Now, let us talk about how these adolescents, when they leave their home environment, where they have medications being given by the drug compliance being ensured by the parents, they leave their home environment, join some professional college, goes to hostels and things like that. So, Dr. Matthew, what do you think? What do's and don'ts will you tell these young adolescents who leave the sort of cocoon of their house, where parental guidance, parental drug compliance ensured, sleep hygiene ensured, everything is happening. Now they are on their own. And it's a different environment. What do's and don'ts would you tell your patients? How do you do it?
Thank you, Rajan. And thank you, the organizers, Gagan and Madam Mangamba. This is a whole lot of problems, and there's a phenomenal amount of anxiety that this particular situation or change of environment produces at this stage for patients with epilepsy. As Rajan mentioned, they were in a protected environment at home. Everything was looked after. Even the drugs would probably have been given by the parent to the child at the right time, and they are suddenly on their own. And so this is a phase where there is a tremendous amount of anxiety, both for the adolescent as well as the parent, because as you mentioned, they are on their own, and each one worries about the other. And this is one problem that is produces a lot of stress for the child also, because the parent is very likely to keep reminding the child over the phone or otherwise about what needs to be done and what shouldn't be done. The other huge problem that they have is whether to reveal the fact that they have an epileptic phenomenon or not. Whether we like it or not, this has still got a tremendous amount of social stigma associated with it, and only extensive public education and awareness is going to change that. And in a society like ours, it becomes an even bigger, difficult, even more difficult problem as such. So who do you reveal this to? Should you reveal it? Yes, you should reveal it. The reason being that it is in your own safety, in the interests of your own safety, that somebody should know. And the question is, whom do you do that to? Probably one way to do it is to ask the patient or the child who is affected to be able to stay with another friend who is very close to him or her. So that he can be told that there is a problem like this, that in case of an emergency, this is what needs to be done. And this particular information should be kept confidential. The other alternative is, once they get into the course itself and they establish a certain rapport and a certain degree of confidence with any of the senior teachers, one of the ways to do it is probably to let that teacher know that they have this particular problem and they might need help in an emergency and what needs to be done. Going into a course, of course, involves having to face exams, irregular hours, late nights, and therefore the stress of studies, which can themselves be triggers for a fit, are always there, and they become more obvious during these times. The way I tell my students is that, yes, these are professional courses, or there are courses which involve a large amount of study, which may be late nights and so on and so forth. So you must be anticipating what needs to be done and regularize your hours or the way you work in such a way that you have a regular amount of sleep. And the sleep is not just in terms of the number of hours you have, it is also in terms of the time frame in which you have sleep, because that is very important in terms of protection from fits or precipitation of fits. So therefore, maintenance of regular hours to the extent possible. That is, of course, something that is a caveat that needs to be done. One of the biggest problems that a child has or an adolescent has when he goes into it is the fear of a fit in class or in the presence of the other children in the class. And therefore, this is something that we have to allay their fears about. This is even more embarrassing when there is an element of incontinence in a situation like that. And then they would become the laughing stock about many of among the colleagues. And this is a real, genuine anxiety that many of these children do have. The way I tell these patients is, well, this is a problem that you have to learn to live with. Once you accept that there is a problem, you know what you need to do about it, and what you need to reduce the chance of ever having a fit, which means regular hours and all the things that we mentioned before. But having said that, it is just another impediment which is part of anything that might happen to you. And I, on a personal level, give examples of very famous people who, with epilepsy, who have achieved phenomenal goals and phenomenal levels of achievement when in periods where there were no drugs available. And Julius Caesar was someone who comes very easily to mind. So the implication of taking it, telling the child that is essentially that this should never be an impediment to what you are eventually going to be able to do, to dream, never stop dreaming, and go on and so forth, given the limitations of some of the lifestyle changes that we have. The problem of, yeah.
We'll come to the lifestyle changes later.
Yeah. The availability of AEDs, the anti-epileptic drugs, is something that they should ensure, that they should see to it that you have a regular source of supply, that the supply should be replenished well before it gets exhausted, so that you do not have to run at the last moment for us. And the bigger problem is, or one of the problems is, that in case they have a fit, there's always a danger or a fear that they may have to discontinue a course because of the fact that the authorities are not easily able to handle it. This happens in off and on when you have fits which are more frequent, and then suddenly the institutional authorities are not willing to take the risk or the responsibility of having it. And I have had instances where children are sent home and then asked to have everything under control before they are able to resume the course. These would be some of the things that we would be passing the child's mind or the parent's mind. And it is very, very important that we preempt all their anxieties by explaining to them upfront what might happen and how they need to tackle it and what they can do to reduce the chance of this ever happening.
Okay, Matthew, taking your observations further, this is where I would like to ask Dr. Dhanya about disclosing that I am a seizure patient or epilepsy patient, and about the consequences of embarrassment of having a seizure in public or in the classroom. These things are very important. Also, we know about 30% of the patients with epilepsy have psychiatric comorbidities like irritability, impulsiveness, aggression, etc. So in such situations, how can you help them? Like either is it, do you think that counseling helps, or do you think medication is required?
Thank you, sir, for that. First of all, I'd like to thank you all for having me here also. It's a wonderful place to share information and to learn. So coming back to the question, I think when we come across children and adolescents who are having to disclose their status to others, it always becomes a very complicated question, not just for the child, but also for the family. Children sometimes are quite open to understanding and are able to realize that, yes, this is a condition that needs to be addressed in the long term. And they need to be kind of making amends, making changes to their lifestyle so that they can manage it and still get along with a happy life that they would like to have. Parents also need to come to terms with that understanding. And very often we see that parents find it equally distressful to have to share the status with others, be it with authorities in school or college, or be it with relatives. And very often that itself becomes a source of pressure. I'm aware of at least a few patients where they are specifically restricted from attending family functions or from interacting with friends or social situations that way, because of fear that an attack would come up, and therefore people would get to know that this child has been taking medications or is facing such a situation. So the stigma associated with it is quite huge, and creating awareness for the family and for the children seems to be the best way to find a solution to it. But it becomes inevitable to share the information. Somebody needs to be informed. Authorities, could be teachers.
Okay. I get your point. The thing is, in such situations, would you like that the patient will require some medication to overcome the impulsiveness, aggression, etc., which is associated with about 30%? adolescents with epilepsy? Or would you think only this the behavioral modification or psychotherapy will help? That is where I am asking.
Okay, in certain situations, we do recommend that they take up medications, wherein we would refer them to the treating team, back to the psychiatrist. Certain cases, but in large proportion of cases, if we intervene pretty early, it becomes easier to manage with behavioral interventions, non-pharmacological interventions, which would involve the child as well as the family.
Okay. Now, I mean, because we'll move on from this topic to the next to Madam Suchitra Narayan, and you have been working with a lot of children with multiple disabilities and problems.
Rajan, your hand is coming in the way.
Sorry. So once Satish Chandra told me, if you tie my hands, I can't talk. Okay. What I'm asking, Chitra, is how often you find that the patients with epilepsy who are well controlled, they've got difficult soft skill impairments, and socially they're not sort of, they don't have much of social skills. What is your experience on that? Well-controlled epilepsy patients. Can't hear. You're muted. You're muted.
Yeah, sorry. I'm not a doctor, so I will not speak medically, but as a specialist, special educator, and having seen multiple cases of children within schools, within colleges, at work environment, what's really difficult for them, like in many situations, there is a problem with processing information. Now, when there's a problem with processing information, it affects language, it affects processing speed. So when does everybody give enough time for the person to stop and think and to respond? Most often not. In schools or colleges, it's like immediate requirement or within friend circles. So they get left out of within the class, within social groups, and that does create problems. So there is a certain amount of hyperactivity in some children, which again affects attention and hyperactivity. So that again affects learning and social skills again. I mean, the impulsivity gets them to act out. And in some, there is a certain amount of motor coordination issues, where fine motor issues, where they are not able to write, because writing is a huge thing in schools. And so they do not get the support of a scribe or whatever that they need to be able to express. They're able to express orally. Some have speech issues. So the clarity of speech is not that good. Then if they have gross motor difficulties, then they are not able to take part in sport activity. Their coordination is affected. So whether it's football, so then the group activities, they get left out because they're not a good footballer or a good cricketer or a good badminton player or whatever. So
we'll come to the leisure and sports later. Okay.
Yeah, no, what I'm saying is it's about the social skills are affected, or their social, the ability to participate in so many activities affected, and that creates a lot of frustration, which in turn leads to either depression or frustration and anger. So then what we see as behavioral issues are actually reactions to the problems that they face. So if we look at why does this happen, I think we need to go deeper and say, okay, these are the difficulties. And unless they get supported for these, then it is only normal that they have these reactions, either feeling left out and being withdrawn, or being aggressive and trying to be one up on the others. So I think it's more than the soft skills are something that are more on the surface. What is deeper is the difficulties that they face every day.
Okay. Now, I mean, I'll take I'll connect this to next, the panelist, Dr. Vinay. Do you think in such a scenario, apart from that age-limited epilepsy, definite, well-defined epilepsy syndromes, do you think that there is an early intervention required from something like a multidisciplinary approach? Maybe first or second or third visit itself. Will it help? And do you practice that?
Yes, sir. It's a very important question when we are going to the management. And as based on the discussion so far, we know that there is a biological issue, there is an environmental issue, and there is an inherent probably an issue with the overall the stigmatizing issue, the social issues also. So here the real problem here is controlling epilepsy. See, when you look at purely from a medical angle, we can say that there are different types of epilepsy. Everything is a disability. If you have an impending fear of a seizure, is always a disability. Okay. So, but when that seizure is controlled and when that seizure is not there, then definitely overall everything improves. So that is 100%. Say in a case of epilepsy, when the seizure freedom makes a lot of difference. But whether it controls everything and the years of previous issues of social isolation, overprotectionism, or over the years, whatever as the child has gone through, and suddenly child has become completely normal. What we call the
burden of normalcy.
Burden of normality. Okay, that is burden of normality is there in the epilepsy surgery circles, but I have seen that in other epilepsies also. See, the main problem is the patient has been protected for a long time, didn't get the social skills, they didn't have the friends to go by, and then they have got a feeling of the self-esteem is a little low when they interact with students. So whether it is the confidence thing or there is a soft skill issue per se, and so it's all very much related. But from the medical point of view, one thing is very sure: if the seizures are very disabling, seizures are occurring every now and then the whole thing, whatever we do with the other things, is going to have a minimal impact. But when the seizures are controlled, then definitely the other multidisciplinary things comes in a big way, and that is the issue here. And then the other thing is definitely the associated issues. Matthew has already told that it depends on whether the institution is able to take them properly, and whether they have got a fear of seizure, whether they have got a good support system, and all these things have a real role. So when we deal with those kind of children, see, usually what happens is when in our system we have the family support, and then when we usually in our day-to-day practice we can try to control the seizures. Seizures are controlled, and to some extent everything goes in that direction, and then they just maintain that, and then they come out of that in as we already know, around 70 to 80% of your patients with epilepsy can have a good control, and then they live with that, and then they can do when we give some support, they will be able to reach a kind of socially acceptable life. But whether we can make it better with a proper assessment of the other skills, soft skills, what is their achievement level in everything, what is their possible, what kind of job they can take it based on their skills. See, that is not only important for epilepsy. I think every adolescent, if you look at that way, the adolescent needs that kind of a support, because to adolescents, actually I have gone through, my kids have gone through the adolescence recently, that definitely they are very confused what is their final destination. So definitely any adolescent needs that. But in epilepsy, definitely this is an added burden, and that will create more problems for them. And whoever has over the years, what I have seen, that the child and the family who takes it head on and then arrange things properly with a kind of confidence, they are the people who are reaching a better level compared to people who are always confused and not able to take it further. But the real caveat is definitely the control of seizures. Along with that, if you we have a multidisciplinary team in our hospital where we try to send back and forth, but that is again a problem in some cases, because that when there is no complaint from their end and we try to dig out things and then we take it out of a kind of deep buried pit, whether it is, I don't know whether it is very acceptable in some cases, that Danya will be able to answer it better. But what I feel is definitely first and foremost thing as a physician is the seizure control, and especially the disabling seizures should be controlled at any cost if it is possible, whether it is by medications or by surgery or any other thing, and then support it with all the other the comprehensive team management that should work at the psychology, the individual level, and also at the social level. So I think with this kind of an approach, I feel we will get the best outcome. Maybe we can discuss.
Dr. Vinay,
Yes.
can I add to that? Because till about 10-15 years ago, there was a complaint that doctors were bothered only with seizure control. Now, do you think that scenario has changed? What do you think?
Yes, sir, definitely it has changed. But in epilepsy, the presenting symptom is seizure, and seizures have to be controlled. Okay, that is my feeling. So seizures have to be controlled, and that should be our prime motto. And then along with that, we can support the other things. Because if the seizures are not controlled, there are a number of studies there. If the seizures are not controlled, everything is dependent on that, especially when they are moving to a single place or in a and then the child has got episodes of nocturnal generalized tonic-clonic seizure. There is a risk to the life also. So it depends. So the seizure control, proper control of medicine, proper control of seizures, proper administration of medicine, and along with the other support, that's the way I would look at it. So it should be a multidisciplinary thing, but we should not lose track of the seizure control basically. Then the primary treatment in epilepsy is proper administration of medicine in 80% to 90% of cases. So that should be emphasized here.
Okay. And now, Dr. Matthew, what I want to ask you is, Dr. Vinay earlier mentioned, sort of went over it, saying that the hormonal problems, etc., during adolescence may affect the seizures as well as seizure control, the result problems with the medication also sometimes. So particularly in young ladies, lady adolescents and young ladies who are about to embark on a career and things like that, I'm sure they'll have a lot of concerns about fertility and other metabolic syndromes associated with fertility, whether it is either associated with the seizure proper or with the medication. So how do you address them? And I mean, do you think that every time that a patient, young lady with epilepsy comes to our office, we should ask all these questions, and if required, immediately get an opinion from a gynecologist or somebody specialized in that? Or should we think that, okay, this is not part of the medication, this could be something else? So if so, how would you like to take it forwards, like change of medication, change of treatment strategy as such?
It would depend upon what stage of life they come to you with. Now, the commonest problem that we have, as Vinay mentioned, is a juvenile myoclonic epilepsy or a juvenile abscesses, which come on at this age, and they probably persist even at the time when they would be about to get married or so. There we used to be in a dilemma where in the olden days, we had only sodium valproate as a drug of choice as far as juvenile myoclonic epilepsy was concerned, and even juvenile abscesses. But the implications of using that drug continuously was, of course, young women would have been a polycystic ovarian syndrome with all its problems associated with it, although it is in a small fraction of those patients. And then, of course, the teratogenicity that would be involved with the use of the drug. Now, of course, we have alternatives. And so the way I look at these things is the way I tell these patients is, suppose this patient comes to you with juvenile myoclonic epilepsy. Now, you know that 80% or 90% of them will have a continuation of fits in case there is a stoppage of the drug after some time. Nevertheless, I do tell these patients, because having to take the drug at the time of marriage is itself a huge social problem. So I give them this option. After about 4 or 5 years of treatment with a drug like levetiracetam or any other alternative that we are using for sodium valproate, we tell them that, look, there is a small window of opportunity where there is a 10% chance that we might be able to reduce this drug and hopefully stop it. Would you be willing to take that chance? And if that is so, you must be fully aware that there is a chance of recurrence. And if there is a chance of recurrence, we would have to restart the drug. If for any reason they had been put on sodium valproate initially, and they were doing well with that drug, when it comes to, that is one more situation in which I would give them the option of trying to withdraw that drug around 18 or 19, so that they get the choice of either stopping the drug in a small percentage of cases, which is purely by chance, or if there is a recurrence, switch to an alternative drug like levetiracetam or what have you. Implication being that the risks associated with it subsequently are much less. The fears of using oral contraceptives or drugs which regulate menstruation and their effect on epilepsy and the control of epilepsy is something that needs to be also addressed. That I'm not an expert in it. I generally get, in case the question is raised, to get the gynecologist also involved. But in general, I tell these patients, if they are approaching you, that you would rather use a different form of contraception rather than oral contraceptives. The other things that they are afraid of when they come, especially at this age, where you're talking about manageable age, is about the social stigma of the epilepsy. Should we reveal that we have epilepsy to the prospective spouse? As a doctor, I always advise them that this is something that you should tell it upfront. You do not make a song and dance about it, but nevertheless, it should be told, because the social implications of not revealing it and the other party finding it out later are devastating. And it usually affects the girl much more than the boy. And one way I tell them is that if you are sure that this is what you want to go ahead with, quietly talk to your would-be fiancé about this, that this is a problem. This is something that I am taking treatment for. It is fully under control and does not create any other problems according to my doctor. And if you have any doubts, we can go together and meet the doctor and he will clarify, rather than tell the parents and then make it a bigger issue, because sometimes that can boomerang. The decreased fertility at the time of using these drugs is of course a problem, and the increased risk of the drugs to the pregnancy itself is something that we always tell them. So if somebody is going to get married, I always tell them, please let me know before you do that, so that by the time you are about to get married, maybe start a tablet of folic acid along with the drugs a week before they get married, and so on. The idea being essentially that we tell them that the risk of pregnancy to the pregnancy is not as much as you think. So when you say that we are using the drugs with the least amount of risk, we have methods by which we can monitor the pregnancy so that the risk is further decreased. When you say that the person has got 3 or 4% chance of a teratogenicity, you're also saying that 96 to 97% of patients will have a normal pregnancy. So the implication is essentially to emphasize the positive rather than the negative. So the fear of teratogenicity is really what is a huge, huge problem. There's another side to this. There are many people who come to you after they get pregnant. They're already on a drug which has probably got more teratogenicity. It is too late to really change the drug, and it is not fair to change it in midstream. So say it's ridiculous that you have done this, but nevertheless, you put yourself in a situation where it is even more risky to change it now. It's better to take a chance with the drug that you are doing because you are well controlled on it. And a huge problem, which sometimes they come out with it, it happens in the more educated group of people. Will I be passing this on to my children? And therefore, the way to tell it is, well, it is only a small percentage of epilepsy which is genetically linked, and the vast majority of them are not. And therefore, the risk of a genetic transfer of this risk to your children is far less than what you think it is. So basically, the idea is to give them upfront a sense of confidence about going ahead with what they want to do, go on to a normal life, and in the process reduce the anxiety that is associated with it, and tell them that for us, this is the commonest problem that we deal with, especially with women. For the men, it is much less, it is much easier to handle than with the women. But even with women, the chances of problems that you anticipate are probably less than 3 or 4%. And we reduce it further by all the newer methods that we have in order to intervene in case of a problem.
Now, looking at this point alone, what is your experience when the patients already revealed, especially young ladies reveal they have got epilepsy, and that has become a big hurdle in their marriage prospects?
I have seen both sides of this, and over the years, I think it is slowly changing. There was a time when people were terribly afraid of even revealing it. They were inclined to keep it secret. And when it was revealed after it happened to come out after the marriage and after a child was born, it boomerangs very badly on the whole relationship.
Okay, so there is some light at the end of the tunnel.
Absolutely. With the newer educated people, especially the younger group who are professional, you explain it to them, and many of them insist that they need to tell people up front that, look, I have this problem, and it is therefore turning to be more positive than it used to be 30 years ago.
That's good news. Yeah. So now, Dhanya, Dr. Dhanya, Madam Suchitra was saying about problems of leisure pursuits and things like that, children with epilepsy, adolescents with epilepsy. Now, again, going back, once they're out of the cocoon of their houses, they go back to they go for a professional course, or they go back, go to a hostel and things like that. Now, there's a lot of peer pressure there regarding leisure activities, as well as even driving. Some of the adolescents I know, they're very passionate about driving. In fact, recently I had a very shocking disclosure from a parent who said that every time the parent and the patient used to come to me, I used to caution, don't drive, don't drive. What happened was, about a month ago, I get a phone call from the father saying that his son had an accident and he hit someone and that person died. So this is in spite of repeatedly counseling them against not driving. It was in another country. So I said, we'll have to look into the driving laws in that particular country. So such cases, how do you address them? Like leisure pursuits, driving, in spite of repeatedly telling the parents and the patient, please don't allow to drive. No, it's only a small distance so you can drive. Nothing will happen. So it doesn't take 5 miles to get involved in an accident. In spite of all that, I have found that it's very difficult to convince the youngsters. What is your experience?
I think so. What you're saying is quite true, because even if it comes to children or adolescents, finding activities that are, what do you say, it's something that people of their age would all be trying, looking forward to doing. But then when we place restrictions, it always becomes very difficult for them to adhere to that and to stick on with the thing of, okay, no driving or no swimming or maybe no alcohol once they get into adolescence. So it helps to find a balance. And I think as a clinical psychologist, very often it helps to listen to their version of the story. So very often children will, or adolescents will have the thing of, everybody is doing it, then why not me? And that's when the seizure kind of becomes like a pressure on them. And they feel, it's all my fault, or I shouldn't have had this. And that leads to a lot of negative cognitions. But it helps to listen to that, reassure them, and advise moderation. Very often moderation helps, as in to understand that, yes, it's okay to be part of the ride, but then not necessarily to drive. And there would be certain strict restrictions or do's and don'ts, which are non-negotiable. As parents, when parents try to, enforce non-negotiables, it becomes very challenging for the parent and for the child. And that's where getting them accustomed, getting the adolescent accustomed to that concept of negotiable and non-negotiable becomes important from early times, from childhood itself. And that's where their parenting skill is also challenged. to
No,
this
no.
extent. Yes.
Apart from driving, I am talking about the other leisure pursuits.
So when they come into a moderation, that's when children and adolescents from childhood itself are encouraged to pick up a variety of options. And we kind of try to help them understand that, okay, all these are possibilities, but you may not be able to take up these because of certain risks. So it's okay to have certain alternatives. So we advise alternatives in terms of could be craft, could be pottery. Some people enjoy certain sports which are non-violent, not very aggressive sports. And that ways we try to help them to engage in those activities, and we help the parents to kind of reinforce their engagement with these other alternative activities.
I can name at least 2 great stars in cricket who were having epilepsy, like John T. Rhodes and the late Tony Gray.
Yes.
So, I mean, cricket playing is, don't say it is not hazardous.
That's generally an argument that a lot of adolescents do come up with also. So it helps to kind of help them see both sides. And like I think with regard to various other aspects also, finding a moderation would be important. So not every sport would help every person. So to find options, alternatives that they can always engage in. That's something that we generally go by.
I think we come to Madam Suchitra. She is very passionate about epilepsy and disability. So what is the current Indian scenario about epilepsy and disability? I think I'm very passionate about such a subject. You're muted.
Yeah, thank you, Dr. Rajendran. Before I go on, I want to thank the organizers, IE and IES, Dr. Gagandeep and Dr. Vangan for organizing this session and the previous sessions, and the whole. Regarding the question about disability and epilepsy, it's been a challenge across India because it is everybody with epilepsy does not have a disability, but there are many who do have a lot of difficulties with their coordination, learning, with their processing capabilities, with their sensory issues. So I would like to, for all of us to dwell on the WHO and the United Nations definitions of disability, which talks of disability as an umbrella term that covers impairments, activity limitations, and participation restrictions. So now if we look at the ability for many of these people to participate in various activities because of certain difficulties, my question is, would that not create a situation where they can say that they have a disability because of this condition? And it is usually long-term physical, mental, intellectual, sensory impairment, which in interacting with various barriers hinders their full and effective participation in society on an equal basis with others. So one of the things that has happened recently since 2016 is the new act which has come about. There were previous acts in the PWD Act, but the Rpd Rights of People with Disabilities Act came up, which again supports the United Nations Convention. And it talks of sensory issues, neurological issues, physical issues, all of which cognitive and mental health issues. So now, when people with epilepsy, when some of them have some of these difficulties and they struggle every day, how can we make their life better or give them a better quality of life by giving them the support that they need? Now, to get the support that they need a disability certificate, because otherwise nobody will give them the support that they need in, whether it is school, whether it is college, whether it is an office space or any other space. Now, to get a disability certificate, they need the definition of disability for epilepsy is not included. So therefore, in India, none of them have that support. And they struggle. And that is, again, one of the difficulties be it getting a scribe in school for writing, where they don't have to write, but somebody can be a scribe for them. They struggle and they know they're better than that. Just because they can't write doesn't mean that they're not good enough. So from there, their anxiety levels are going up. And then we talk about problems in behavior and problems in social skills and soft skills. And, I'm just giving one example. So we can talk a lot about that. So I think it's high time we take up this issue at a national level and look at it. And everybody, the counter to this with learning disabilities, when it came under the Learning Disability Act, many people said no. Many of students will misuse, many persons will misuse this system. Many human beings in India misuse the ration system. Does that mean that we don't provide rations? So there are many things in our society in India where many people misuse so many systems, and yet those systems are being used for the benefit of people who really need it. So I think we need to look at it from a social, from a rights-based perspective, where we improve the quality of life of every human being. And if we can improve the quality of life by giving them this support, I think it's something that the IEA and IES can really work to make it happen for people who really need it.
Your point is well taken, and I think we should work towards that. But 2016, one amendment was post-traumatic epilepsy with more than 6 seizures a month. They'll get 40% disability. I mean, that is the amendment which came into the 2016 Act. Okay, we will take it forward. I think as a body, we are responsible to do it. And that is our job, to be an advocacy group for this, this problem. Now, there were some questions and answers which had come earlier.
Dr. Rajendran, I'm Dr. Manjari here. May I interject?
Yeah, please do.
So to add to the last part, we at AIMS are evaluating people with epilepsy under, physical and then intellectual disability. And if they have, there's a scoring which is there. And if they fit into that scoring, that is, they're having recurrent seizures, there may or may not be a physical inability. And of course, the neuropsychologist does the IQ assessment or the neuropsych assessment. And then there is a discussion among 3 people in a panel, and a disability is issued to deserving people. So this comes under chronic neurological disorders, and it is well accepted by people who are using that disability for benefits. These benefits could be tax exemption for the parents. It could be, getting access to the caregiver, traveling with the patient from a distance. So for under the disability benefits, the caregiver would be able to have concession for travel, and the patient too. So we are issuing, I don't think it's an issue which it cannot be done. What is to be remembered is that all people with epilepsy are not disabled, and that is the message which should go out there. And those who have a physical or intellectual or recurrent seizures do get the certification.
Yeah. Thank you, Dr. Manjari. I think that point is well taken. But the thing is, such cases, come under the ambit of cerebral palsy and such children. We are talking about patients, like for instance, 2016 Act specifically amendment says that post-traumatic seizures, more than 6 seizures a month, without any other disability, are also eligible for 40% disability certificate. That is a point which had come up. Anyway, thank you, Dr. Manjari, for the information. Now, some questions had come up which were earlier before our talks. One is the need for a support group for patients with epilepsy. Second thing is the inclusivity in educational institutions. Then problem of delay in diagnosis. So these are 2-3 questions which had come. So I think I could ask Dr. Vinayan to answer these questions.
Yeah, sir. I didn't get it clearly, sir. The last part, I didn't hear it properly.
Delay in diagnosis, that is the last part.
Okay.
Because one of the patients had to wait for a long time. Finally, it was diagnosed as probably a gliotic scar, which after epilepsy surgery became all right. So epilepsy surgery is not very much, people are not aware. There is a delay in working up for epilepsy surgery, I think. You can,
Yeah, say the message at this platform, I'll say is that 80% of epilepsy is eminently treatable with drugs, and you can get control and decent living with good control of seizures in 80%, whether most of them or majority of them may go into a remission, and especially childhood onset epilepsies. So, but 20 to 30% of epilepsies may not get response with the traditional anti-epileptic drugs at this point. So we may need better drugs for that. Over time, we may get more medicines, which may be specifically targeting some of these resistant to treat epilepsy syndromes. But at this point, there is out of this 20 to 30%, a good number, I will say 50 to 60% may go in for especially the focal epilepsy group. So that can be amenable to surgery. So the basic issue here is when the seizures are not controlled with the first line adequately treated medicines, adequately treated drugs for a sufficient period of time. If it is not responding, then definitely this patient needs proper further evaluation for a possible epilepsy surgery, because an epilepsy surgery is a game changer in this kind of group, where a significant number of patients can get seizure freedom also. So it's not only seizure control, a seizure freedom. So that group of patients definitely needs an early evaluation. But otherwise, in a general epilepsy population, definitely the message is proper intake of medicines, proper control of lifestyle will definitely able to control around 80% of cases.
thank
And
you.
so one issue I would like to mention, sir, with a lot of time here is a social issues of insurance and all. Somebody was mentioning that, sir. So that is one thing which I have found. Epilepsy is many cases of epilepsy, especially if we say it's of genetic origin or anything related to, when we definitely call something genetic generalized epilepsy or something like that, immediately the insurance is having a problem. So we as a forum, we may have to work on this. And I would like the IEA to take this up in a significant way, because the current literature, according to current literature, we are forced to put it as a genetic generalized epilepsy in a majority of cases. So genetic epilepsies. So that is a real problem for many of our patients at this point.
No, I get your point, Dr. Vinayan. Now, there are a lot of senior people who are in the audience, and the President has said, the Secretary General said, Dr. Satish, I can see Dr. Sita Jayalakshmi. What are your comments on the issues which we have raised?
So we will give back to Gagan then. So we'll can start.
Dr. Gagan can set the ball rolling.
Yeah, I mean, I think you have really covered the entire spectrum, for adolescents and young adults, starting from job issues, schooling issues, marriage issues, and driving. And then the issue of disability. And the last point which Dr. Vinayan emphasized was this genetic generalized epilepsy. And indeed, there is a lot of controversy, and a lot of people are not very happy with the use of the term genetic generalized epilepsy. But I also think that, having reviewed some of, I think there is a genetic contribution to almost every epilepsy, even if it is acquired, and that's one of the ways of thinking about it. But how do we go ahead and put it across to the patient? That is a different thing. There we believe that even some of the acquired causes, some people with head injury never have seizures, and others have seizures because they are genetically predisposed. So, I mean, question is whether we put it across the right way to the patients, or just tell them that but certainly I agree that there is an element of stigma or an element of fear that goes with the term genetic generalized epilepsies. So I think
again, the issue was whenever we put this genetic or a gene thing here, the insurance people are not accepting that. So that is a special issue with the Indian subcontinent, or in our population. So that is one thing which we may have to work.
For that matter, epilepsy does not. Epilepsy is a big rule out in most insurance schemes.
Yes, that's the problem.
That is the issue.
That is a major issue.
Is a huge issue which needs to be kind of taken up.
Yeah, the issue now is even if you get a history like a febrile seizure, and then you want to take a medical insurance, and then there is a disclaimer that if you had a seizure in the past, you are not supposed to, or many insurance companies are not accepting their proposal.
Yeah.
So that is one major issue. So I have given now at least 2-3 cases the certificates that is all cleared, and that's why they have not disclosed it earlier.
Yeah, so these are some of the important issues which we do face, and the issue about driving is also something Dr. Rajendran very nicely and clearly. People just don't consider driving from home to the school or to the college or to their place of work as driving. Driving is when they actually drive in a car. Sometimes they will just say, he doesn't drive, he just drives a bike or a scooter or something of that sort. So that is, for them, driving is when you actually are on the highway with a car and something of that sort, which they say, okay, no, he doesn't do that. So the problem with our country about driving is, public transport is not easily accessible. In many countries, there is social support for people with epilepsy to use public transport, which is not the case here. And then public transport might not be so easily accessible. So it's important for people with epilepsy to drive, but at the same time, we need to think of their safety. And so it is indeed a big dilemma as to what to tell. And, you have to listen to them, you have to tell them what is right also. But at the same time, you have to, understand what their way of thinking is and what they think about the whole thing. So it's extremely complex and extremely, it is indeed a very difficult situation, and we need to find out ways of going ahead with this and, sorting this problem out. But I think it's extremely important to involve people with epilepsy as important stakeholders in whichever way, whichever path we actually go ahead. So I think that's the key feeling.
Thank you, Dr. Gagandip. Dr. Vengama, and I see Dr. Chanda also now on the screen. Your comments, please.
Madam, you would like to say something? Or, Madam Vengama? Am I audible?
Yeah, but there is
Not
some
very
echo.
clear to me, at least. It's
There is
breaking.
some echo.
Okay, can I? Hello. I just wanted to share 2 things. We had done projects on epilepsy And one of the projects which showed the
Your voice is breaking. I just can't get the clarity.
Okay, what about the others? Are you all able to hear me?
Not clear, madam. No.
Similar
Clear,
problem. Similar problem.
Oh, okay. Even now it is not clear?
Slightly better.
Is it okay now? Am I close? I'm closer to the mic now. Is it okay?
It's better.
Better.
Okay. So the thing is, I wanted to share about the medication adherence, wherein we had found about 20 to 30% of the young adolescents and the adults come into the group wherein they had shown a very, a significant level of non-adherence to the anti-epileptic medications. So I think the clinicians, probably the neurologists who are attending to the patients, should make it very clear to the patients, saying that medication adherence could be one of the problems, and therefore they need to counsel right in the beginning. So that is one thing. Now, second thing is about young adolescents, they abuse and misuse the medication, substance use rather. So wherein majority of them had, they were abusing alcohol and they were smokers, and, some of them were into drug addiction as well. So these are all not only the trigger factors, but also, they would affect the medication, anti-epileptic medications that they are taking because of the pharmacological factors wherein the pharmacokinetics comes into the picture. So these are the two issues which we need to kind of, tell the patients right in the beginning, saying that if they are taking the medications, they have to be off the medication, the drug abuse or the alcohol abuse, things like that. So I think medication adherence to anti-epileptic medications and stopping or avoiding the alcohol and smoking are equally important. So these are the two things which one needs to emphasize right in the beginning of starting the treatment with the patients, particularly the young adolescents and the adults.
Thank you, Dr. Chandra. Dr. Vengama?
Rajan, would you excuse me a minute? I have to leave. Would that be okay? There is something else that has come up suddenly.
Okay.
I'm sorry, and thank you so very much.
Thank you for joining, Matthew.
Yeah. Thank you.
Dr. Vengama?
Yeah, like as I already mentioned, adolescence is really transition and they'll face a lot of problems because of social situations and then physiological and hormonal. I think all the issues which are faced by the adolescent group have been covered well, starting from the schooling, driving, and other issues. I think all things have been covered quite much. But I think what we have seen in our routine, this one for that age, acceptance of the diagnosis is the most difficult, especially when we say your investigations are normal first time, why should I get, what is the reason? And they, at least this age group compared to other group, they just insist that please let me know why I got it, why. I think this group needs extra counseling hours, though the control of seizure and other part, but I think they need a lot of extra counseling hours and extra visits to make them convince and accept the diagnosis. I think once they start accepting, maybe we'll follow compliance, all those things. Most of the time when we say, doctor, everything is normal, why should I get it? I'm all right, why should I get it? Please let me know. You do whatever you think to find out the cause for that. I think so much of explanation and counseling is required. That's what I feel. Compared to other groups like elderly and children, parents may accept, but this adolescent group, we need to counsel a lot and try to make understand. And most of them, this adolescent group with the Google doctor, they know half of it, and we have to spend time to counsel and see that whatever the doubts are cleared until they get convinced of the diagnosis, till they accept the diagnosis. I think that should be the major responsibility, which sometimes we find difficult. After second, third visit also, they'll say, should I still take drugs till I got the diagnosis? You think that to repeat investigation, will it help? Something like that, they go on. I think that acceptance part has to be examined. Even the parents have accepted, but this especially adolescent children will not accept, like, problems faced during the school, college, other peer groups. And that's the reason I think they have a lot of denial of that part of it. I think that's the major challenge, at least I feel we as a clinicians face. But all the topics are very well covered, Dr. Rajendran, all your team of doctors like Dr. Vinay and Dr. Thomas and Dr. Suchitra and Dr. Danya, you have covered important aspects of epilepsy, which are seen especially with adolescents and young adults. It's nice. I think we have all 15 minutes.
Before thanking, I think the take-home lesson today for our association is work on the aspects of epilepsy and driving.
Rajan, please speak loudly. Yeah?
After today's discussion, I think our group as Indian Epilepsy Association and Indian Epilepsy Society, we should work on three things. One is driving, one is disability, one is insurance. So with these three things foremost in our mind, can we close the meeting? And I want once again to thank both the President, the Secretary General, and all our panelists and all the people who have been our audiences today. I don't know what number is there, but I want to thank all of them and wish you a very good evening. Thank you.
Thank you, sir.
Thank you very much.
Thank you. Thank you, the entire Kochi team.